Hello everyone. Today we are going to start our cardiovascular system proper, and we are going to start with our part 1, and in that we are going to discuss about the functional anatomy of the heart. We are going to not get deep into the anatomy of the heart, that will be dealt in the anatomy, but here there are some functional elements which we will be constantly referring back during our physiological lectures. So we should know the bare minimum and the names of it. So let's get started. So first of all, why do we need a circulatory system? Like we are supplying water to our home, in a similar way, the circulatory system is the one which is supplying blood to all the organs, which in turn is supplying the oxygen and taking up the carbon dioxide. And this has to be done on a day-to-day basis multiple times. So like we compare in our house, the motor for our circulatory system is nothing but our heart. The most dominant player here, that is the heart, is the motor system. And what is the water in our circulatory system? The water is nothing but the blood. And as you can see here, in a house also, we have multiple different types of vessels. In the same way, even in the blood system, we have different types of blood vessels. So they are going to carry this blood throughout the body and supply it and take away the metabolites that is found in the body. So let's begin the session with few more questions. At the end of the session, we will be able to answer all of them. So first thing is, why the cardiac muscle act like a syncytium? Some of you might hear this syncytium term for the first time. It means that they are working together. So why the cardiac muscle acts like a syncytium? That is, they are working together. And how is it possible? Obviously, they have to work together, but how is this possible? Like all of them has to contract at the same time. The ventricles has to contract at the same time. So how is this possible? We'll try to understand. The next thing is, why myocardial infarction? Myocardial infarction means it is the ischemia of the heart where the heart is not getting adequate blood supply and there is the tissue damage, which we commonly call as heart attack. This is very common on the left ventricle. Why is this so? We'll try to understand it. And the athletes at rest, they have bradycardia. Brady means slow, cardia means the heart rate is slow. So that is called as bradycardia. Whereas in infants, it is the reverse of it. What is it? The infants will have a higher heart rate. So that is the difference between an athlete and an infant. Let's try to understand which system is getting this control. So let's begin the lecture. First, coming to the chambers of the heart. All of us know that human heart has 4 chambers. That is the right atrium and left atrium. The smaller chambers are the atria. So on the right side we have the right atrium and on the left side we have the left atrium. So these are the RA and LA. This is the right side. So for all our discussion purposes, this will be on the right side and this will be on the left side. And these diagrams will come back again and again throughout the lectures. So this is the right atrium and left atrium. And coming to the ventricle, so this is the right ventricle and this is the left ventricle. As you can see here, this is the right ventricle and the other side is the left ventricle. So these are the 4 chambers of the heart. So these are the 4 chambers of the heart. And obviously, like a motor pump, it should have some input also. So what is the primary input for the right side? For the right atrium, it is our superior vena cava. That is the major vein which is coming and draining into the right atrium. And inferior vena cava. So these 2 vena cava are the 2 major veins which are going to get its blood supply from all other organs and put it in the right atrium. They usually bring the deoxygenated blood. And on the left side, the left atrium will receive its input from pulmonary veins. So pulmonary means the lung and it is going to receive its input from the pulmonary veins. So these are the inputs. From the right atrium, it is going to go into the right ventricle and from the left atrium, it is going to go into the left ventricle. So coming to the valves of the heart, there are various valves in the heart. So there is some valve which is connecting the right atrium and the right ventricle. This valve is called as tricuspid valve. Tricuspid valve. Why it is called tricuspid valve? Whenever they have seen this anatomical structure, it was having 3 different cusps. 3 different cusps means there are some elements which are just acting and closing the valve. So these are the tricuspid. Tri means 3. So it looks like this, like a Mercedes symbol, and there are 3 cusps, 1, 2, 3. Whereas on the left side, it is also called as mitral valve. Mitral valve. And usually the mitral valve is also called as bicuspid valve. Bicuspid valve. Why it is called bicuspid? Yes, very rightly said, because it will have 2 cusps. Only 2 cusps it will have and a division between them. So the bicuspid valve is going to have 1 and 2 divisions only, 2 cusps. They are together. Sometimes we will represent them together as atrioventricular valve. Why? Because it is connecting the atria and ventricle. So both of them together we can call it as atrioventricular valve. We should be very frequently adapted to all these terms. That is why I am repeating again and again. So this valve is atrioventricular valve, means it is the tricuspid and the mitral together. And from the right ventricle, it is receiving the blood from the right atria, which is deoxygenated. So it has to supply it to get some oxygen from the most important organ, that is the lungs. So from the right ventricle, the blood supply will go into the lungs to get oxygenated. So what will happen? So whenever it is traveling it, there is a valve which is closing and opening depending upon the requirement. So this artery, we can call it, this artery is nothing but our pulmonary artery. Pulmonary means that is the lung. So it is going to the lung, so it is called as pulmonary artery. And there is a valve which is guarding the opening between the right ventricle and the pulmonary artery. That valve is called as, again very simple, it is pulmonary valve. And from the left ventricle, the blood supply is going to all the organs. So there is one major artery which is going from the left ventricle and supplying all the organs. That is nothing but the aorta. So what is a valve? It is pretty simple. It is an aortic valve. So this valve is called as aortic valve. Is there any common name to represent both this valve? Yes, there is one common name which represents both of this valve. And these valve, they look like half moon. So this common name is also very similarly related to it. That is called as semi-lunar valves. So the valves are semi-lunar valves. So these valves are very important because constantly we are going to study about them. So tricuspid, bicuspid, which is the atrioventricular valves, and pulmonary and aortic valves, which is the semilunar valves, which from when the left ventricle and the right ventricle the blood supply goes in. Now coming to the two circuits. As we understood, from the right atrium, what is going to happen? The blood supply is going to the lung via the pulmonary artery. From the lungs, where it is going to go? It is going to go into the pulmonary veins, which is going in turn to drain into the left atrium. So what has happened in between the process? The lung has oxygenated the blood that is incoming from the right side of the heart, and from the left atrium it will go to the left ventricle, and through the aorta it is going to supply the entire systemic circulation. So we have two circulation, one is the pulmonary circuit, another one is systemic circuit. Obviously they are connected, but these are two circuits. And the pulmonary circuit has a low pressure. Here the blood supply is going to only one organ, so the right ventricle has to give very little pressure to reach that organ. So this system is also called as low pressure system. Whereas the aortic side or the systemic side, when the left ventricle pumps, the blood supply has to go to the entire body. So obviously it is a high pressure system. High pressure system. So basically the left ventricle has to work harder. So is there any benefit or disadvantage to it? We will see in the coming series. That is the high pressure system. So these are the two circuit systems which we have it in our body. Now coming to the covering of the heart. We saw about the various different chambers as well as the valves. Now covering of the heart is called as pericardium. Peri means around. Peri means around. So around the heart it is forming a covering, so it is called as pericardial layer. Now sometimes what will happen is there can be an inflammation because of infection of this pericardium. If there is such inflammation happening in this pericardial layer, then the disease is called as pericarditis. And itis is a term which is used for inflammation. So if pericarditis means there is an inflammation and infection. Due to infection, there might be an inflammation which is causing this pericarditis. And sometimes there is a gap between the pericardial layer, and this gap usually is called as pericardial sac, and it has some little fluid like the lubrication for the heart, like lubrication for any motor system we do. It is going to lubricate and keep the heart in a constant position. But sometimes pathologically what can happen, there can be accumulation of fluid or blood. There is accumulation of fluid and blood surrounding the heart. Is it good or bad? It is very bad, because now they are going to compress the heart itself so that the heart cannot relax and it cannot properly pump the blood to the other organs. This type of like fluid accumulation or blood accumulation is called as cardiac tamponade. So this is one of the serious conditions, and it should be treated as an emergency, and the fluid or the blood that should surrounding the heart should be removed at the earliest possible. So this disease or the pathology is called as cardiac tamponade. Now coming to the various different layers of the heart. So when you cross section the heart and split it out and see, then what will happen? The outermost covering is the pericardium. We know that it is the pericardium. In the pericardium also there are two different layers. One is called as the fibrous pericardium and another one is called as the serous pericardium. So these are two coverings, serous pericardium. And then we have the pericardial sac, that is the gap I said, that is nothing but the pericardial sac. Then we have different layers of the musculature of the heart. There are three different layers. Starting from the outer, it goes inside. The outermost layer is called as epicardium. Epi, as the term indicates, outside. So remember these medical terms. Epi means outside. Then we have the myocardium proper, that is the muscular layer, which is the proper myocardium, that is called as myocardium. Then innermost layer, epi is outside, then endo means inside, endocardium. So these are the various different layers of the heart. So we should know about the various different layers also, and there can be inflammation happening in these layers also, and corresponding name will be given, that is endocarditis, epicarditis, myocarditis, like that. Whenever there is an inflammation happening in these layers, it will be named. Now coming to the cardiac musculature itself, the cardiac muscle is there, and out of this cardiac muscle there are some muscle fibers which is going to contract. That is called as the proper myocardium. The function of this proper myocardium is nothing but contraction. So obviously the heart has to contract to send out the blood. So this is called as contraction of the myocardium. And there is something called as modified myocardium. What is this modified myocardium? We will see in the next lecture, but still I will give you a hint. First, the heart is contracting, but somebody has to tell the heart to contract at a particular rate. All of us know that there is some like battery kind of thing which is inbuilt in our body, which is nothing but our SA node, and obviously the SA node has to generate and it has to conduct through various different parts of the heart. So this part is called as the modified myocardium. So modified myocardium is nothing but the conduction system of our heart. So this is nothing but the conduction system of the heart. So this will be our second lecture. So I am giving hints here itself, so that when we continue the second lecture, we should know conduction system means it is the modified myocardium of the heart. Then coming to the cardiac muscle fiber nature, the cardiac muscle fiber is also belonging to the striated group of muscle. And why it is striated? Because it have the contractile elements, that is the actin and myosin. Whenever there is an actin and myosin, the muscle are arranged in a pattern, they will create some striations which will look striated in this cardiac muscle. And next thing is the heart is involuntary. Like if I think to stop the heart, will it stop? It's not going to stop because it is involuntarily happening. So it is under the control of autonomic nervous system, that is the ANS, autonomic nervous system. Now when you talk about the muscular structure of the heart, there is some important things that we have to understand. There is a disc which is connecting between the cell to cell connection, that is nothing but an intercalated disc, and inside that intercalated disc there is one beautiful connection between one cell to another. As you can see here, it's like a tube which is connecting two blocks. So what is the advantage of that? Whatever ionic change is happening in this block, it can be immediately transmitted to the next cell. And they have said that this connection looks like as if the cytoplasm of one cell is in continuity with the other next cell. So they are continuous. Like it means that it's not like a single cell is separately happening. It is in continuous with the next to next cells. So now let's break the silence that what is this junction which is connecting between the cells? That is nothing but our gap junctions. So this gap junctions is one of the greatest advantage for the heart, because if some information is happening in one cell, it will be immediately transmitted to the next cells, and further the information can be conducted from one cell to another very fast rate. So this gap junction are forming the electrical connections. They are also called as synapses, electrical synapses, and they transmit impulse at a very rapid rate. What is the advantage of this is, for example, let's imagine the entire myocardium is like this, and if it contracts at the same time, it is of benefit. And for example, if it is not contracting, like one part is contracting, the other is stationary, is it of any benefit? Can I push the blood out properly? No. All of them have to contract properly at the very same time. So this is done with the help of this beautiful junction, that is the gap junction, and it is made up of the proteins called as connexins. So it is connecting one cell to another, so that's why it is called as connexins. So this is all about gap junctions. Now we will understand that which property or who is doing that contraction together. That is the syncytial property is given by which element? It is done because of the presence of gap junctions or the electrical circuits. So the cardiac muscle can act like a syncytium. How? Because of the presence of gap junctions. And these gap junctions are called as low resistance bridge. So they are called as low resistance bridge. And this syncytium will act in two different parts. The atria is going to contract together and the ventricle is going to contract together. Atria and ventricle, we don't want them to contract at the same time. Why? Because if they are contracting at the same time, blood will go from atria to ventricle, ventricle to atria. It is not going to go anywhere else. So first the atria has to contract and give the blood to the ventricle so that the ventricle will receive the blood. After that, it will close this valve, because when the ventricle is contracting, I don't want it to go back to the atria. I want it to go back to the pulmonary artery in case of right ventricle, or in the case of aorta, it will go from the left ventricle. So the atria is going to act as a proper syncytium, the atrial syncytium, and ventricle is going to contract together, causing the ventricular syncytium. So this is the beauty of these two, atria and ventricular syncytium. They can contract together, and maximum effectiveness or the benefit is got from this mechanism, that is the syncytial property of the heart. Now there is some special arrangement in the case of left ventricle. So all of us think that the ventricle is contracting like this, but ideally how the ventricle is contracting is, it is like as if it is squeezing, and after that it will recoil back. Squeeze it and recoil back, squeeze it and recoil back. That is the type of action that the ventricle is happening. So as you can see here, the endocardial fibers are oriented on the right side, like towards the right side, and the epicardial fibers are oriented like this. So their orientation itself is different. So whenever they are contracting, they are going to squeeze it out, and then it is like a spring loaded action. They will squeeze and then send out the blood. And why this is little benefit is because when it recoils back, it can recoil back at a very faster rate. And now coming to the question, why myocardial infarction is common on the left ventricular wall? Obviously, we know that now itself. I have told you few hints. The first hint is the left ventricular musculature is more. Why it is more? Obviously, it is supplying blood to a bigger area, that is the systemic circulation throughout the body. So this musculature is more. If the musculature is more, what is going to happen? The oxygen demand itself is increased. Whenever there is a demand is increased, and even a little less blood supply, whenever decrease is there, so whenever there is a supply demand mismatch, what is going to happen? It is going to go for an ischemia and finally causing an infarction. Next thing is the pressure generated is very high. For example, the pressure that is in the aorta that during systole is 120 and during diastole is 80. Where does this pressure come from? Who is giving this pressure? It is obviously the systolic pressure is given by the left ventricle, which has to pump at a high pressure of 120 mm of Hg in comparison to the right ventricle, where the pressures are usually around 25 mm of Hg. See the comparison. Right ventricle is just pumping at 25, it is doing less work, whereas the left ventricle is very hard working, but it is the one which is going to suffer an MI. So not only hard work is important, at the same time we should work smarter. So left ventricle musculature is more and it has to give up high pressure gradient. And because of this, during a systole, the supply can be compromised. To left ventricle, leading on to a myocardial infarction and causing an ischemia. And again, they might say that sometimes it is the subendocardial region which is having the MI most of the time. In the left ventricle also, the myocardial region, as we understood, epicardium is on the outer side. So epicardium is here, whereas the endocardium is on the inside. So whenever the blood supply is coming, the blood vessels come from the outside and supply inside. So they are coming from the outside and supplying the inner area. So the outside area, they are not going to be compressed. But whereas during the ventricular contraction is happening, what is going to happen? These blood vessels which are going inside the myocardial musculature, they will also be compressed because they are inside the muscle. Since they are passing inside the muscle and supplying the endocardium, whenever it is going for a systole or a contraction, what is going to happen? The inside vasculature is also going to be compressed, and this part, the endocardial part, is the one which is going to get least amount of blood supply. So that is the reason why the endocardial region of the left ventricle is the most common site for a myocardial infarction. And because of its hard work and everything, even though it supplies on its own, but sometimes what happens is, due to severe demand is high and the vasculature is also compromised, the left ventricle can go in for a myocardial ischemia or infarction. Now coming to the cardiac innervation. Now what about the cardiac innervation? The cardiac has the nerve supply, that is the autonomic nervous system. Autonomic nervous system has two elements. One is the sympathetic system, another one is the parasympathetic system. As we can see from this diagram, the sympathetic system is the one which is coming from the thoracic region, whereas the parasympathetic system, the supermost innervation is by the right vagus and the left vagus. And in this diagram itself, pay attention very closely. The left vagus is going and supplying the AV node and the atrial part a little bit. The right vagus is going to the SA node and atria again. Is there any parasympathetic supply going into the ventricular part? No. In human heart, the parasympathetic supply just supplies the nodal region predominantly and some amount of atria. It is not going into the left ventricle or the right ventricle. Whereas the sympathetic system, they have their influence on the SA node, AV node, as well as the atria and the ventricular musculature. So in the ventricular musculature, sympathetic system is the predominant control, whereas the parasympathetic is the one which is controlling the node predominantly. So what are the actions of sympathetic? So whenever the sympathetic hyperactivity is there, what is going to our heart rate? The heart rate is going to increase, it is going to pump harder. So all these effects, there are specified names for it which we must try to understand. So it will have positive. Positive means it is going to impact it in a positive manner and increase it. Positive chronotropic effect. We are talking about sympathetic. Chronotropic means it is the heart rate. There is an increase in heart rate. Then inotropic means force of contraction. So there is going to be an increase in force of contraction. Then dromotropic means it is a conduction speed in the conduction system. Conduction system I will discuss in the next class. So conduction speed, and especially at the AV node. So this is conduction speed. Then bathmotropic means excitability. Excitability of the heart. The heart is an excitable tissue. All of us know that when we give a stimulus, it is going to get some action potential and give a contraction. So excitability is going to increase, and even the rate of relaxation. Contraction is increasing. At the same time, the relaxation also will happen faster. That effect is called as lusiotropic effect. So it increases the rate of relaxation or the speed of relaxation, we can say. Whereas the parasympathetic system has negative impact on all of them. That is, it is going to decrease the heart rate, decrease the force of contraction, decrease the conduction speed, decrease the excitability, and decreases the rate of relaxation. It is just exactly opposite to that of the sympathetic system. And we have to address a few more things with respect to this cardiac anatomy. What is the basal heart rate? Basal heart rate means at rest, whatever heart rate we are having, that is the basal heart rate. What is the normal basal heart rate? Average is around 72, but the range is around 60 to 90 beats per minute. So as you can see here, this is the range, but average is 72. At the baseline, do we have sympathetic and parasympathetic system? Obviously, yes, because we are intact human beings. So we have both the supply of sympathetic and parasympathetic, that is plus. So plus means the sympathetic and parasympathetic system is intact, like both of them are influencing the heart. Now coming to the second term, which is called as intrinsic heart rate. What is this intrinsic heart rate? Suppose heart is there, and normally we have definitely the sympathetic system also and parasympathetic system also. Now what if we cut both of it? So what is going to happen? The heart is not getting any innervation. The heart is going to beat on its own. Will it beat? Yes, of course it has a pacemaker which can generate at its own pace. So whenever the sympathetic and parasympathetic system is cut, what is going to happen? The heart rate is going to beat at 100 beats per minute. So this is the funniest thing. Like when you cut them, the heart rate is increased. Now, for example, we rejoin the sympathetic and parasympathetic. What will happen? It will come to the basal heart rate, which is around 72 beats per minute. So what has happened? When sympathetic and parasympathetic system both are given the connection, like we are putting it back to connection, the heart rate has decreased. Now tell me, which person has the ability to decrease the heart rate, sympathetic or parasympathetic? Obviously, we just saw the parasympathetic one is the one which is going to decrease the heart rate. Now, after giving both the connection, the heart rate is down. So now tell me, the heart rate is maximally influenced by which system? It is maximally influenced by the parasympathetic system, because after giving the connection of both of it, the heart rate did not rise, it came down. Who can bring it down very significantly? The parasympathetic system. Even though the sympathetic system is there, still it is overriding it and it is decreasing the heart rate. So parasympathetic system has greater influence on the baseline heart rate. So first is basal heart rate, means the natural heart rate which is present, both sympathetic and parasympathetic is present. Whereas intrinsic heart rate means when both of them are cut, the automatic beated rate without the innervation of the autonomic nervous system is the intrinsic heart rate. And parasympathetic system, as we saw, has a maximum influence on the heart rate itself. Now coming to the two important scenario, what happens in athletes? athletic people, they usually have bradycardia at rest. So bradycardia at rest. Bradycardia means it is decreased heart rate. So decreased heart rate is going to happen in athletes. So the reason we just have discussed. So which system can act and decrease heart rate? It is obviously the parasympathetic system. As and when a person is training, what is going to happen is the sympathetic system will get activated, but for the recovery, the parasympathetic system is going to come and act, and it is going to bring all the values to the baseline, and this strengthens the parasympathetic system, and their parasympathetic influence is going to increase multiple folds, and because of which at baseline the athletes have bradycardia. Whereas in case of infants, what will happen is in infants normally naturally their heart rate is more than 100, and they have at baseline itself tachycardia. It is normal for an infant, but when you compare it with the adult rates, it is tachycardia. And what is the reason is the in infants the parasympathetic system is not well developed. So the parasympathetic is not well developed, and because of which the infant is going to have a higher heart rate. So these are the some reason or questions we should know for the MBBS examinations, and it is a must know area, these reason out questions. So it is easier to remember and you understand it conceptually, so that when you read on further topics, it is going to build beautiful amount of concept, and it will be easier for you to replicate and remember in the exam sessions also. Thank you for watching the video. We'll see you in the next video. Thank you so much.